there is no cure for depression. It's an episodic illness, in the sense like cancer. There's only remission. That's the actual word that we use, is going in remission where you no longer have the symptoms.
Today's episode is about depression, what it is, how to recognize when you might need help, and what treatment options are available. I'm sitting down with Dr. Joshua Brown, an Assistant Professor of Psychiatry at Harvard Medical School and a world-renowned researcher specializing in Transcranial Magnetic Stimulation, or TMS, for depression. The topic of depression is personal for me. I've lived with depression for years, tried multiple antidepressants, but they never really helped. It wasn't until I completed an accelerated TMS treatment at Dr. Brown's clinic that I finally began to feel better. That experience is what brought me to this conversation with Dr. Brown today. My goal with this episode is to offer information, insight, and perhaps a bit of clarity, whether you're going through depression yourself or supporting someone who is. This episode is for informational purposes only and isn't a substitute for professional medical advice. Let's get started. In my experience, trying to navigate this mental health journey, I was diagnosed officially with depression last winter. But I was in that kind of state for a long time. I just did not feel
Pursue it.
yeah. I didn't feel like it was bad enough to actually do something. But then I was I didn't know it could be different. So then, I guess, so I came to the...
How long would you say you had felt that way? Since you didn't
Since
know it could be different.
2018.
Okay.
It was and then I moved to the US and it was basically not very good. Yeah. But also I feel because in Russia, which is where I grew up and went to high school, it's a very stigmatized topic, and it's not anybody would tell you to go to a psychiatrist and get help. It would be an insult.
Yeah, right.
Yeah, so I guess it wasn't in my head. Yeah, so then I guess last year my friend encouraged me to actually do something.
Yeah.
And then I went to the student health services here, I guess, and then there was an entire math was trying to get a therapist and other things. So okay, my first step was to get a therapist.
Okay.
So I came to this Harvard Health Services, mental health whatever department, and then they were supposed to give recommendations of therapists based on my preferences. And then I was well, I need a female therapist who understand something about my background, being Russian and stuff. So the first person that they recommended me was a guy who specializes in man-focused therapy.
Okay.
And I was that's not very helpful. Yeah. Anyway, so I was a bit discouraged.
Gotta have a good fit with a therapist.
Yeah. Yeah. So that was not a very good start. And then
and by the way, we should make sure we talk about the stigma aspect.
Yeah.
That's an important topic, so we should talk about that when we get there.
Yeah. I guess for me, for some reason, for me it's not. I think because of maybe it's just the people I surround myself with, my friends and others, I don't feel it's stigmatized anymore. I'm pretty comfortable talking about this.
That's good. That's good.
Yeah. Anyways, and then eventually I had an appointment with a psychiatrist maybe 2 months later because the wait time is so long.
Okay.
And they prescribed me an SSRI. The most basic one, sertraline.
Sertraline is one of the most common ones.
Yeah. So I tried that. It did not go well. I had a lot of side effects, all of the common side effects that you can have. I don't know if I should list them.
And how long did they last?
So I took it for a couple of weeks. And the moment I started taking it, I was just immediately
the side effects started.
Yeah.
A lot of times side effects will last only a couple days as you get used
to it,
and then they'll go away. So usually that's why I asked how long.
Yeah, it was a couple of weeks. But then my psychiatrist would say that you should wait maybe up to 6. Sometimes you can only see the results 6 weeks later or something.
Yeah.
But it was
benefit takes a while to happen.
Yeah, and it was pretty hard to take it for a couple of weeks because it was just only exacerbated.
Yeah.
All the side effects and anxiety and irritation, just it was really bad. So I stopped taking that, and then the next one that I tried was bupropion, which is SNRI.
It's actually
or something.
DNRI, be dopamine norepinephrine.
Oh, okay.
Yeah.
Yeah, so I guess it's also like pretty common.
Yeah, very common.
It might be unrelated, but like also like the moment I started taking it, I had like double vision. So like things started,
Yeah.
weird.
Yeah.
And I've never had that before. Like I never had problems with my eyes.
Yeah.
So, and anyways, I had to go to the ER and like see what.
Make sure that there wasn't something
Yeah.
going on.
Anyway, so like I got scared. I stopped taking that too. Then I took a break for a bit, and then I guess a couple of weeks or maybe months later, I decided to try, or like, and didn't decide. My psychiatrist was like, you should try Cymbalta,
Okay.
which is not very common, I guess.
It's fairly common. Yeah, it's pretty common.
Okay, so I tried that. It was like the worst. Because
And that's an SNRI.
yeah. So I took it one afternoon, and then the next morning I woke up. I woke up like with rashes like all over my body, and I was like trying to get out of bed, and then I got like very dizzy, and like I passed out completely.
Mm-hmm.
And then I hit my head like face, and like I had to go to the yard like stitch my face.
Oh my gosh.
So like
yeah, that's
really like a strong.
That's a pretty strong adverse effect. Yeah.
Yeah. So I didn't like that. So, and after that, I stopped taking everything, and I sort of got discouraged.
Yeah.
Because it's like I tried 3 times.
I understand.
And it's like didn't work. So I was like, okay, whatever. I guess I'm just not gonna do anything. And it was like last May.
Okay.
Yeah, and so like after that, I basically gave up. But then I came across this YouTube video from Tim Ferriss about TMS, and it sounded amazing, magical, kind of. But also like I think like for me what was important is like I sort of trusted that person. Like, he comes from like he also went to Princeton. He's like kind of like smart person. Like he's not gonna like say random things.
Yeah.
And then I was like, okay, maybe it's something. But I never heard about it before. It's like sounded strange.
Yeah.
Well, you stimulate your brain, like I don't know.
Yeah.
Yeah. So then I talked to my psychiatrist. I was like, there's this thing that he didn't tell me about.
Yeah.
Maybe I should try it. And then I guess he sent the referral form.
Okay.
McLean.
What was his response when you brought it up?
Honestly, he wasn't like very involved. He was like, sure, you can try. But I mean, the only thing he said was like, usually it's like you only get approved for it when you try like 4 or more antidepressants.
Yeah. That is how it's been. One of the shifts, fortunately, movements is that insurance companies, as it's getting better and better established and the evidence is growing and growing, insurance companies are getting better at covering it. And so most of the policies now have shifted to 2 medications, 2 antidepressants. And that's quite recent. Like in the last year, a lot of these have happened. Some even 1 antidepressant. So, and I can, it's probably a bit boring and it's probably not as interesting, but I can tell you about why that transition, like why it was in the first place. And there's kind of silly reasons behind it, but like insurance stuff it's unfortunately a big part of what we do. And, it's like not science, it's not whatever, it's just trying to get people coverage. So like when someone does a trial, a randomized control trial that produces evidence to be able to say that this is something that we should do, they will try to, first of all, they'll choose patients that have not responded to 1 or 2 or more medications, because if you pick people that have never been on a medication, there's a high initial placebo response, and you're trying to essentially create a separation from placebo, and we call it sham with TMS, just the same thing. And so insurance companies will say, well, the trial that this was done in, this was in people that had not responded, and I'm probably going to at some point say failed, 2 antidepressants or something like that. And, we're trying to kind of change the nomenclature a bit. And it's like the patient didn't fail, like the medication failed, right? The patient. So forgive me for probably, saying things in that way, but that's the way that it's kind of been described for a long time. And so you have, in order to keep the sham response, the placebo response low, they'll choose these patients. And then insurance companies will say, well, the trial was done with patients that had failed 2 antidepressants. And so we're only going to cover that. And then they'll kind of glom onto anything that they can that would say most of the people in the study actually had not responded to 4 or more. So that's what we're going to cover. And, I trained in South Carolina with Mark George. He was like the sort of the pioneer of TMS for depression. And so it all started there. And in the insurances there, they actually had a rule between 2 and 4. So if you had more than 4 that you're not responded to, you don't qualify. If you had 2, like less than 2, then you don't qualify. So they were going, and that was probably more in line actually with what the data was, because there's some other data that shows that more than 4 and you have a less chance of response. And so in different insurance companies will have different rules. And so we actually have to check with each individual insurance company, with every person that comes in to see if they'll cover it. Right now, pretty much across the United States, pretty much everybody covers it for depression. And I can say like most of the countries worldwide have fairly robust system, especially in like Europe, Australia, Asia, Japan, stuff like that. Have pretty good coverage, but there's some places that are still, even in Canada, like where insurance is not covering it and they just do trials, like as a way of getting people in. But OCD, sorry, I was just gonna say OCD, that was FDA cleared in 2018. And there's still like half of insurance companies don't cover it. And so it takes a long time for insurance companies to sort of come around and be like, okay, we're very convinced of the data. We're willing to invest our money, which is precious, to, cover these things. But that's, as I kind of mentioned at the beginning, that's shifting to where, we get, there's 2 recent studies, for example, that people that had responded to 2 medications they randomized them to get another medication or to augment medication or to get TMS. And in both studies, TMS was clearly superior in terms of, creating that response. And so, it's like, I think it makes sense, even as a TMS person, I as a general psychiatrist, I would start someone on a medication first. It's easier to just take a medication than to come into the clinic every day and get this kind of thing. But when you have adverse effects, or if you're not responding to it, we want to be thinking, and the whole field is evolving quickly, and we're trying to sort of educate and train everyone about this, and, insurance companies included, to sort of shift to be thinking about going to TMS after 2 medications, for example.
I was curious, like, so you say, like, it's easier to put somebody on antidepressants as opposed to do a TMS. But then I guess, like, my understanding so far is like antidepressants is like a temporary solution, which like it could make you feel better for some time, but then as soon as you discontinue, you can go back.
Absolutely.
Versus TMS kind of promises to be more
durable
long-term solution. So
so the durability aspect is an important point. And the reason I say easier is because it's like you have to drive in, right? So it's like 20, 30 minutes, you gotta find parking, you gotta go in. And so,
there's no TMS.
Yeah, exactly. And so it's difficult. And it's difficult even if you live somewhat near one, it's a good hour out of the middle of your day or something. Whereas if you can just take a medication, it takes 2 seconds, So, that's part of it. But the durability part is an important point. And a lot of times people get on a medication and then they'll start feeling better and they're like, do I really need this medication anymore? And then they might want to get off of it, and then they might relapse and come back. And so it's like the medication can help prevent those relapses. TMS, you can also relapse. TMS is not like a permanent thing. It's not a cure. There is no cure for depression. It's an episodic illness. It's, in the sense like cancer, there's only remission. And that's the actual word that we use, is going in remission, where you no longer have symptoms. Similar to cancer, you no longer have the cancer. Nothing's detectable. You're in remission, but there's the predisposition towards it, and it can always come back. So you got to keep monitoring and that kind of thing. We usually will cite that more than half of people will stay well beyond 1 year, and we actually don't have a very much longitudinal, like long-term data. There's 1-2 studies that have looked out to people, that far naturalistically. And that's the numbers we found. Like more than half of them stayed well up to that point. So it is quite good for durability. It compares really favorably to like ECT, which is, we would say maybe 6 months is that kind of turning point. Other modalities like deep brain stimulation, this is not an FDA cleared indication at this point. There's still trials, and I think probably eventually we'll get to that point. There's some strong work in that area, but it's so far it's failed at kind of pivotal trials, and there's some reasons for that. That we could talk about a little bit as well if interested. But we think that we understand why it didn't work. But as soon as you turn off a DBS stimulator, say let's talk about tremor or Parkinson's, what's most commonly used for it, pretty much instantly those things come back. And so the way it's working is sort of as you're giving it, it works, and then as soon as you stop, it doesn't. We see that with OCD as well, where does have an FDA clearance with a humanitarian device exemption for OCD. And that's, I mentioned that just because there's not like a huge amount, like a huge body of evidence for OCD with DBS. I realize it's not like the main focus of this conversation, but it's in a small group. It had like such a profound impact that the FDA gave clearance for it for that reason. But, stories, not my own personal experiences, but colleagues that I work closely with will say, like the DBS, like battery will die or something. And then people just really kind of go sort of, they'll be in like a very bad place very quickly because of that. So yeah, and you depend on a follow-up in that case. So that is one great thing about TMS is that you get the treatment and then it's like, you don't have to worry about a device. There's no implantation. Vagus nerve stimulation is the other kind of implantable form. And that is FDA cleared. And the really good thing about vagus nerve stimulation is that it's got really good durability effects. So studies up to 5 years show that people are still getting better up to that point. So when, if someone hasn't responded to other things, or if like they just keep relapsing quickly and you really need some of that durability, that's where I usually recommend VNS to people. But it still requires surgery in the neck and an implantable battery that's like a pacemaker under the collarbone. So
yeah, I have so many questions. One thing I think is like important to hear from you, especially it's like if I have depression like that, I need to get treatment.
Yeah.
And then I go talk to my psychiatrist or like PCP or whoever. Like what sort of things should I think about in order to choose like the best treatment option for me?
Yeah.
For example, why am I asking this? Because in my experience, the way I was prescribed those antidepressants, for example, it was like, just take this, it's gonna work, like that.
Yeah.
And for example, and when you're not in a very good place, like you don't think super clearly.
Yeah.
For example, I did not think about durability, right? And it's like an important point, right? You start taking it as a friend, but like you kind of need to know how long you're gonna take it, and like
and then kind of and it's sort of like well, maybe indefinitely, right?
Yeah, exactly.
And it kind of depends on how you respond to it. So in the reason, it's like it's not surprising to hear what you're saying, because there's literally no antidepressant that's like clearly better, or that's even clearly better for a specific subtype. There's kind of a science of psychiatry and an art of psychiatry, and the science is like there's not a superiority. There's mirtazapine, Remeron like has some differential effects in terms of their trial showed that they can get effects in 2 weeks, and so it can be a little bit faster. But most of what we do in prescribing medications is kind of the art side of things. And so there's some medications that we think, oh, these are a little better for a more anxious kind of depression, like sertraline and especially Lexapro or escitalopram. Citalopram similarly. Prozac can be, fluoxetine like can be a little bit activating. And so if someone's like a little bit lower and like more dysphoric or a little bit more of that like low energy, you might think of that, or the bupropion would be one of the things that we would definitely look at. SNRIs, so the Cymbalta you mentioned, like the duloxetine, or venlafaxine, Effexor, or desvenlafaxine, like these would be, these noradrenergic components. We would think, yeah, that should enhance the energy level a bit and the activation component of things. Remeron is a noradrenergic medication. And then there's side effect things. So if sleep is an issue, mirtazapine, heavy like anticholinergic component in the initial phase causes fatigue. And so it helps people sleep. If someone's not eating very well, it causes weight gain through the same mechanism. And so we might try to like leverage the side effects to try to get them something that would be helpful to them. If hyperphagia, overeating is a problem, then Wellbutrin, is probably the best medication from that standpoint. And so there's the combination, and it's not just with depression meds, but with, psychosis meds, anxiety, etc. With all things essentially, the data and the evidence not showing any superior to one another, then it's a matter of like, okay, we kind of get a sense that these tend to help with this, this kind of, subtype of depression. And depression is definitely not one thing. There's like 9 different subscales, and we think that there's probably different networks in the brain that are subserving each of these. And so you can have potentially hundreds of different kinds of depressions. And I think there's a lot of parallels with the brain to the body, not surprisingly. They're both, it's an organ of the body, so it would kind of make sense. And diseases like cancer that we talked about before, pneumonia, like these have many different causes and subtypes. And it's like we're in the early stage of the brain is so much, arguably, so much more complex than the other systems. It's taking longer to figure out, and it's the abilities to sort of assay its function have been the last to come. And so that's why the neuroscience is like this last frontier. And that's why things are stigmatized still in psychiatry, because we just know the least about them. Like there's things that used to be stigmatized, like epilepsy used to be quite stigmatized, cancer, similar. Like, so, many, if not all medications at some, or certain diseases at some point have had some stigmatization, and it really comes from like a lack of knowledge and awareness. But grounded in the understanding that like these are symptoms that come from the brain, which is an organ. Like that is the thing that I think is eventually helping. And so as we're getting better informed, I think that's why we're seeing less stigmatization of it. And then as we start talking about it more, then it becomes even less stigmatized. And it becomes like, okay, this is, in the same way that we're not going to criticize someone for having an inflamed appendix or, something like that. Right. Yeah.
Can you talk more about what is depression? Like you mentioned, there are many different subtypes potentially. Like, what do we actually understand, like scientifically?
So depression there's a lot that we know. So like you can find, 10 different things occurring with something happening. And it's hard to know like which one is causing which without, the ability to really like look in and see. So, we know of a number of things that occur with depression and things that are, that get corrected with it. So it's such a big question. Let me just give you first sort of the way that I see depression. We have brain circuits, and, as we're talking, like these brain circuits are interacting with each other and coordinated with our language centers and our understanding of things. And they're active in this way. We have circuits, and these are part of larger networks that are responsible for normal mood, and they're responsible for motivation, and responsible for anxiety and being over anxious, and either appropriately or not enough. So we have all these different, all the different symptoms that we have. We've got things that are part of this. Things can be overactive inappropriately or underactive inappropriately. And so it's not just like a increase, decrease alone. And there's a high degree of interactivity. Like you might have this kind of direct pathway, but then you have inhibitory connections that are tuning that, in the way that would want to be. So depression is essentially a kind of a, I hesitate to use the word imbalance because of the whole chemical imbalance thing. But it's essentially like, circuits or networks that are not functioning properly, and that weren't able to adapt. And a lot of times it's like it can kind of start sort of slowly and it can kind of build. And I sometimes think, as we try to with therapy, we try to retune or reconnect these in different ways. And I think of talk therapy as often being very similar to like physical therapy, or even just kind of like a retraining, right? Like if someone has, even a professional golfer, they'll, someone will analyze their swing, like, oh, you're messing this up or you're doing this wrong. or not in the best way. And so they'll have to like even Tiger Woods had to like redo his swing to get better, right? And he was amazing, with what he's doing. So there's always like room to improve. As far as like therapy, I actually think it would be ideal if every person, on Earth could have a therapist and someone that they could essentially help them to learn more about themselves. Because these things all can kind of go into an effect. Now, if your form, is kind of bad enough, you can kind of develop injuries because you're not doing the thing properly. You could say the same thing with really any sport. And I like to use a lot of analogies with sports, especially because, I sort of think of it that way. Yeah, kind of like going back to depression and what that's involved. So you have, and so what does that mean if you have dysfunctioning or improperly functioning networks? You might have the connections between neurons are called synapses. And this is really where like kind of the major action zone is. A lot of there can be problems within the neuron itself and its ability to transmit, but we don't detect that quite as much, maybe with like epilepsy and stuff. But a lot of the things, or multiple sclerosis, we lose the wrapping around them. But a lot of the stuff, it really kind of is at the synapse level. And that's where a lot of these medications, the medications kind of act to tune up or tune down the efficiency of the synapse, more specifically the efficiency and ability to change its strength. And so when you learn a new thing, you essentially, we know are developing new, either a new synaptic connection or strengthening an existing synaptic connection. And that's going to be part of a circuit that's involved in that. And medications can help to modulate that. Talk therapy can help directly strengthen that just through repeated action. And that's the way that you can naturally strengthen these. Like learning and memory are synaptic plasticity. Synaptic plasticity is learning and memory. Like it's what's happening at the cell versus what's happening phenomenologically, right? And that's kind of where TMS comes in. Is I'll just speak of TMS instead of all brain stimulation. We apply it to particular brain regions that are involved in these functions, and we'll maybe focus on like a node where there's multiple networks kind of coming out of there. And through, we give a whole bunch of pulses. And the reason for that is the same as like rehabilitating a muscle or something like that. Like you got to do a lot of repetitions to be able to do that. And we think that in that process, we have something called long-term potentiation or long-term depression, depending on which way we're pushing or pulling it. And we're trying to change the strength of that synapse, which ultimately changes the strength of the circuit and the network involved. And so I think of depression, to kind of get back to your original question, as sort of a dysfunction or improper function of key networks that are kind of mediated by synaptic plasticity. And so we want to get that ball rolling. And so one of the sort of proposed endpoints of depression is where we see a lot of things funneling together is brain-derived neurotrophic factor, BDNF. This is something that we see, that's aberrant or it's kind of off in depression, and it gets corrected, when it's in place. And that's a key mediator in plasticity. I think that it could be potentially like a downstream effect, but it's unclear what the driving thing is. And that's where I think more biased towards this because I trained in the area, but that's kind of the way that I see it. As I see it, it's sort of it's more driven by this process of synaptic plasticity, and we know that plasticity is impaired in people with depression, and that's what we protocols that can enhance the efficiency of TMS are things that would enhance LTP and things that would enhance synaptic plasticity. And so I think that there's some increasing evidence that this could be sort of that driving factor for how we experience depression. Does that make sense?
Yeah, it does. It's like, I'm just curious, like, do we actually measure, like, are able to measure the synaptic plasticity and understand how like different?
That's a really great question. No, in a human, we can measure an indirect correlate of it. We can look at the changes in the physiology. So we can look at EEG or indirectly EMG responses, and we can see, okay, how much muscle excitation are we getting pre versus post? How much, with our EEG, like brainwave recordings, how much can we modulate these? And so that gives us sort of more of a global measure, to really know if something is synaptic plasticity, you have to look at it through conventions like patch clamping into a single cell and recording the currents from that, and looking at the receptor levels, which require like confocal microscopy and imaging of very small layers of tissue. And so we can look at those things in animals. And so we're actually trying right now to sort of, get a model for, rats and monkeys and humans where we can kind of do the same protocol and then see if, okay, what we're seeing here corresponds, and we see the same thing with motor evoked potentials, for example, as a way of looking at plasticity. And then if we can kind of do that same protocol, we're seeing the same response in the animals. And so then the next step is to say, okay, with that same protocol, are we getting these changes in, I'll mention a few jargony things that we look for, like the GLUA1 subtype of an AMPA receptor. If those are increased, that tells us that we're seeing an LTP-like response. Is there changes in PSC95 and CAM kinase 2? And, so it's very molecular. That's what LTP is. And so what we look at in humans is an extrapolation. And so we can't be 100% sure, but we can get really confident if we can kind of do this cross-species validation.
What about like this chemical imbalance idea? Because I feel like, okay, for me, when I was trying to read about it initially, especially, I feel like 85% of the internet is against. And like, I feel like when I was I was trying to remember, but I feel like the way people presented it, it was like, that's what it is.
Yeah.
And like, even my friends from like also doing a PhD, right?
Yeah.
And they're all like, yeah, obviously, it's just an imbalance, and like, obviously, it makes sense to take medication that's like supposed to like that.
Yeah.
So like, it took me quite some time to like realize that maybe like it's not exactly.
Yeah. So like, where does that come from, and why is it?
Not necessarily, but there is history, obviously, but like,
the question
it's not a helpful way to think about depression, or like, yeah.
Well, you'll notice that as I described depression, I didn't use that. I talked about network and circuit imbalance, but chemical imbalance. That this is a term. I think the history is a little bit important. Like, so in fact, I'm going to back up even a little bit further. So, the first antidepressant, it was an antituberculosis agent, and it was being given, to this group, and they found like mood elevating properties. Like, oh, interesting. And so they started to use these things, and then they found that these older medications that many of which are still in existence and are quite effective actually, but do have more side effects. So when they started to synthesize, they essentially were able to kind of, very smartly, like go back and figure, okay, what are the key components of this? And they found serotonin was a major factor. And so fluoxetine was like, this sort of first generation of deliberately designed medications that could do this. The SSRIs, and this is like in the early 80s. And so this is kind of like where this idea spurred of we want to adjust the chemical, like you're not having enough serotonin, so we're going to give you more serotonin. Actually, in the synapse, and it will kind of show. I remember sometimes I've given lectures in the past where show like one of those like 80s videos, commercials where it shows the synapse and chemicals kind of crossing there, right? So there's actually, it's not really a problem of the chemicals in the synapse. The issue, if anything, is the receptors in all likelihood. And so it's like, if it's just the chemicals in the synapse, then why wouldn't you get better within minutes of taking the drug, right? Like, and we all know very well that it takes weeks to notice the effect. And so we think the mechanism of antidepressants is more likely that it's triggering some downstream effects to actually change the transcription and translation of proteins that are encoded as receptors and increase the sensitivity to the mediation. So it's important to understand, like, antidepressants are really modulators. They kind of tune up or tune down the excitatory transmission. That's like the mediator of these circuit effects. And that's why I kind of frame things in the sense of circuits. Because that's actually kind of what's happening. And so the brain is an electrochemical organ, and really all of the pharmacology sort of subserves to promote the electrical propagation of these signals. And so it's instead of, I would think of the pharmacology supporting the electrical properties rather than the other way around. If that makes sense. So yeah, so certainly chemicals are involved. The brain has this chemical component to it. And it's an important part of things, but it's really the electrical properties that, action potential is moving down an axon, and then you stimulate, release of neurotransmitter, which activates receptors. And then this causes a graded depolarization, which then moves down the cell and then gets past the cell body. And then once it's past this axon hillock, then it initiates another action potential. And then you're starting to create a circuit at that point. And so it's like, I kind of mentioned that it's kind of like the basic principles of neuroscience with an individual neuron and how they communicate with each other. But that's really, I think highlights the interaction between the electrical and the chemical component. But it's not just, there's some other drugs that we do that do have an immediate effect, right? Like a lot of the things that are quite reinforcing and that become habitual or can become addictive, like those tend to have immediate effects, and those do act, directly on those synapses in that way. But we think that the antidepressants change more of the cell's machinery, like the DNA transcription and protein translation, so the creation of new proteins. So that's kind of why it takes time, and so that's where the shift has gone, and that's why you won't hear psychiatrists talking about you have a chemical imbalance.
Yeah, that makes a lot of sense. Then also I was curious, so you mentioned there are different subtypes of depression potentially. Can you elaborate on that? And also I guess from the point of view of a patient who might have some symptoms, what exactly is depression from that side of things?
Is that a separate question from subtypes or?
Yes.
Okay, so two questions.
Yes.
One at a time. So subtypes, I can say we don't know all the different subtypes. Again, we're still at this fairly early stage. One of my good friends and colleagues, Sean Siddiqui, actually, who's a brain imager, found that across multiple different data sets, that if you divide depression into two main subtypes, dysphoric type, and they call it anxiosomatic type, so more anxious, sometimes you get somatic kind of symptoms from that, like bodily aches and pains and things of this nature. So, these both map onto two different kind of brain networks, and they're distinct from each other. And kind of more recently, we're seeing he completed a trial looking at this, found that they actually, if you stimulate TMS in different brain regions, more the axial one here and the dysphoric one here, these in the dorsolateral parts, these actually produce differential effects. And so it's once we start to get more of a sense of, and I would say that's probably if we were to divide into two just to start, that would be kind of probably one of the most basic distinctions. And then within those, there's multiple things that would separate as well from each other as you kind of get more fine-tuned with it. We hope, those of us that are doing research in the field and even just practicing clinically, we're hopeful that we'll be able to get to a greater level of precision as we continue to work on this. And it takes time, because you got to do trials that show and demonstrate, right, that this is a different circuit. We see this sort of in retrospective things, but then we can also actually say, we can test our hypothesis and show, it actually makes a difference. And so there's lots and lots of work being done in this regard. And so there's a lot of neuroscience, kind of across the board that's really interested in these questions, and knowing anatomically where in the brain to stimulate is a big part of it. And then even it gets a little more complicated, but even the subtypes of neurons in a particular region, what you're preferentially trying to activate, gets even more tricky. Especially within the TMS field. That's one of the things that I love about TMS is it's such a great tool to be able to test out some of these things and learn more about the neuroscience of it. It's theoretically, if we had just a perfect knowledge of everything, then there probably would be hundreds of types of depression. At this point, it's still helpful to kind of lump together just because we have, some idea. But, 15 years ago, the NIH, the National Institutes of Health, who fund most of the research in the country, in the United States, probably 90%, they tried to kind of move away from these DSM diagnoses, the Diagnosing and Statistical Manual. This is what we use, and it's more of like a dictionary. It's like a language. It's not like a ground truth, right? And so there could be, we see that there's a lot of similarities across different neurologic and psychiatric disorders. Sometimes there can be more differences between two people with depression than someone with depression and, Parkinson's, or depression and Huntington's, or depression and anxiety or something. And so it's like they termed it RDoC, research domain criteria. And so they said, we want more research to be focused on these sort of domains rather than on these diagnoses, which don't map onto the biological reality of things. Does that make sense?
Yeah.
But it's still, it's still useful to have a common language and to know sort of these, what these things mean. And I think that when you see something that's effective across depression, it means I look at it as there's a big enough signal to noise ratio that we're able to pull an effect out of a very heterogeneous population.
That's so interesting. Yeah, I think it's kind of like related to how like my psychiatrist approached it. It didn't really make sense to me at that time.
Yeah.
But he was like, I was trying to get a diagnosis, right? And then he was like, well, we're not treating diagnosis, we're treating symptoms. So like, let's focus on the symptoms.
Yeah.
Which I guess sort of makes sense.
Yeah, no, it does make sense. Like, and it's, the diagnosis is just basically a way that I can say, instead of like, you have symptom 1, 2, and 3, and A, B, and C, you have this entity that comprises this and some other symptoms as well. But it kind of, because they do sort of group together, and they likely group together because they likely share a lot of common circuitry. So it's, it's like, if we only ever stayed on individual symptoms, then we wouldn't have it, we wouldn't have a way to be able to, treat this or that. But ultimately, when we kind of, as psychiatrists, we tend to think a little bit less of like depression, antidepressant. And we tend to think a little more of like, your energy's low, noradrenergic, medications could help that. Or your anxiety is high, like a serotonergic, and a specific subtype receptor might be, particularly helpful with that. So that's, so it's a little bit different than how you might think of it at a more like rudimentary level.
I feel like also like another thing that like took me a while to accept was like, or maybe it's like partly because like I haven't dealt with like a bunch of medical issues before. But to me, I felt like medicine should be rigorous.
Yeah.
Yeah. And then like when you say like there's like a big part of it is like just art and like figuring it out, it's like, I'm not super comfortable with that, or like I wasn't. But like I guess now as I'm learning more about medicine in general, like from my PhD, like just in general, it's like it makes a lot of sense, and I feel like it's like a different attitude.
Yeah, as you said that, it reminds me of when I was in undergrad, and I wasn't planning on doing medicine at all, or anything like science, and then I became exposed to like the physiology of vision, and I was like, oh my gosh, it's so amazing, like this is actually how it works. And then I decided I'm gonna go to medical school, and I'm just gonna learn all about how the brain works. And I don't know if I'll, I don't really have an interest necessarily in doing medicine. I just want to like learn all of it. And then as I got into the classes, I was like, wait a minute, like, I'm like asking questions like, well, how does this work? Oh, we don't know. How does this work? We don't know. And then and she's like, one of my teachers was, professors was saying, if you want to do this, maybe you should do an MD PhD, where you can do the research to figure out these things out. Like, oh, like we have to do studies and like research to actually learn these things. And so then you kind of start to appreciate all the nuances of everything else. And so that's, that was the thing I pursued. And then also, you talk about like the rigor, like there's obviously like you go through medical school, and then you do like an internship and so forth. And so there's kind of the way that we practice medicine. And then I did a neurology and psychiatry residency. And, the way that we practice neurology is really totally different than the way we practice psychiatry. And, part of it's kind of the nature of the diseases, part of it's the way we can add, I mean, almost by definition, it's like if you can see it on imaging or if you can see it in pathology slides, then it's neurology, right? And so that changes the way that we work. If you can see it on laboratory assessments, then it's like it almost makes it neurological disorder. And that's a whole another topic that I could, talk a lot about. I think of it more as brain medicine because all of these symptoms, whatever they are, like they're coming from the brain. And so it's, let's basically leave it, simply as that. But yeah, it is. It really is lacking a lot of rigor in the sense that, it's like I would consider myself someone that's very attracted to that rigor. Like I'm a scientist, neurologist. These are, we would consider highly rigorous things. And it's just simply the fact that there's so many unknowns still, and it takes so long to figure all those things out. And so we do what we can with what we have. I mean, if we were having this podcast 100 years ago, first of all, we'd be very advanced for our time. And secondly, like we would be talking about like almost nothing, like there's really like nothing. So the advancement in knowledge is just absolutely exponential, but there's still a lot that we don't know, which just speaks to like the complexity and the immensity of the brain, which is why I went into it, because I thought it was amazing and fascinating. So and still do.
So excited. Yeah. Oh my God. Wow. Can I talk a bit more about like going back to the question about, I guess like it's more about like, I'm a patient and like I think I might have some sort of symptoms, but then I'm not sure like what is depression and like how would you kind of like talk to this kind of people or like help them understand whether they might actually have depression, or like I guess like the question is,
so you're having symptoms, like you feel something's not right, but do I have depression? Is that?
Yeah. Or I guess like okay, maybe like in my specific case, it was like I have some symptoms, but like maybe they're not strong enough for me to actually go and do something.
Yeah.
And it's like,
so maybe I get what you're asking.
Also, I feel like because it's not rigorous, it's not like take a test and like for sure tell something.
Right.
It's like another.
What's my serum level?
Exactly.
For depression. Right. Oh, you got it.
Yeah.
Yeah. So what was like? I think it could be illustrative to know what is it that you kind of described your past, and started in 2018, and then you got here, and then it sort of just in the last year or year and a half.
Yeah.
What is it that made you cross that threshold to like, I'm gonna go talk to somebody about this? Like, what you first went, you had the student counseling and stuff like that. What was the thing that sort of made you cross that threshold? Yeah.
Okay, I did think about it. So what I realized before is, like, for example, in my undergrad, right? Even though there was like a lot of discussion about like mental health on campus, people didn't really talk about medication. So like I never really considered. Like, people talk about therapy a lot. Like you should get a therapist.
Yeah.
So like that's the thing that people talk about, or like talked in my undergrad, which is fair. But then I guess like I didn't have anybody around me who like ever took an antidepressant or like talked about it, or never thought of it as a possibility.
Yeah.
And so therefore I was like I didn't know that there are like solutions, like actual medical solutions to this. And so like I did have a therapist, which was not very helpful. So I was like, okay, whatever. So
did your therapist ever say anything
no,
about that?
No, exactly. Like, okay, that's the thing that like maybe was wrong, or like, yeah. So I had like, for example, this therapist for like 2 years, and like I had all these depressive symptoms there then as well. But like she never like encouraged me to like actually get it diagnosed or like get on medications or something. So like I never thought about it. And then I think last year, just because I guess some of my friends also were like going through similar things, it was like, okay, maybe that's like a possibility.
Yeah.
So I guess like that was like just general awareness.
Yeah. I think that what you're asking now is like maybe the most important question that we'll talk about today on this. it's like pretty much every patient visit that I have, I want to arm the patient with knowledge so they can advocate for themselves, because as providers, we're not perfect and we're going to miss things. And we're not going to, whether it's unawareness or, whatever, it's like, so I think it's so important to try to inform and educate the individual so that they can advocate for themselves, as opposed to relying on someone noticing or someone catching or some, whatever. So I have no idea, what the reason is, that a therapist would see someone that's just not getting better, not responding, struggling, and not, recommend that. Like there could be some, valid reason or something for that. But that's kind of, I'd say my main motivation for being here with you is so we can kind of talk about this and arm everyone that's listening with this knowledge. And so it's like, if speaking of the DSM that we knocked already, if we look at that, there's something that is an important point, which is it has to cause some impairment in functioning. And and that's kind of the important distinction. Like if someone's functioning normally, even though they're experiencing some sort of symptoms, then it may not lead to the diagnosis. And usually you kind of have to have a diagnosis to get a medication or have insurance pay for it and that kind of thing. Not that it might not help if it's sub that threshold, and function could be, you're not doing quite as well in school, you're having a harder time focusing at work, and you're maybe not like performance is not as good. Maybe it's affecting your relationships, you're more irritable, so there's many, many ways that it could affect function. So vex function to the point that you're like, that someone were not eating adequately and they're losing weight, or they're like, having suicidal thoughts or something like that. And that's like emergent, and, it really is like need to go into the hospital, which is usually typically just the ER. And that's pretty much how our system is set up here, at least in the United States, for people to just go in and they have, avenues, directions to get help from there. But probably most people are, much more commonly would be at the point where it's like, okay, I don't feel quite right, or I don't feel maybe quite like I used to, or maybe I don't even feel quite like I should. And so it's sort of understanding where those symptoms are. So let's say that's kind of below that threshold. So above is this clinical level, below is like a subclinical level, and you're experiencing various symptoms. So that might be a place where, maybe it's not quite to the level of a diagnosis. And that's where I think, like therapy is like an excellent place to sort of focus on that. But if therapy is not getting you to the point that you need to be, then I think, for anyone watching, that's kind of part of this conversation, would become aware that that's, that would be what you'd want to do. And to maybe to pull on some of the way that I think of like physical analogies, like even for me right now. So I have an appointment on Friday with an orthopedist, and I've had this nagging knee injury, which is really bothering me because I like to do a lot of, sports and stuff, and it's limiting me, right? So my function is impaired in that regard. And so I kind of dealt with it for probably like 5-6 months. And then I noticed when I started to ski, I was like, oh, like it's really affecting my ability to ski. And I don't like that at all. So I stopped running because I thought that might be contributing to the problem, so you can kind of see parallels with all this. Like, maybe you're feeling depressed, and maybe it's because you're drinking a lot or using marijuana too much, or, something like that. It's like, okay, so you try to kind of stop things on your own that you could think might be causing that thing. And I think it maybe helped a little bit, but it didn't quite help all the way. And I basically spent the next, 4 months or so focusing on rehabilitating it to the extent of my knowledge. Like I know, some about how the body works. I'm not a physical therapist, I'm not an orthopedist, but, I kind of applied the principles that I knew of. And, I had some idea of, I want to strengthen my VMO, and I'd had a little bit of meniscal problems before. And my diagnosis, my amateur diagnosis is that it's a meniscal tear, meniscal deterioration. And so I eventually reached the point where I'm like, okay, this is not getting better. It's not getting worse, but it is still impairing my ability to do all the stuff that I want to do. And so then I finally called and said, I need to get an appointment because I either need to get some help with the rehabilitation side of things, maybe there's some other thing that I'm not aware of, there are injections of chondroitin sulfate or something like that. And so that's when I decided to reach out for help. And I think that I again, like thinking of the brain as a part of the body, which I assert that it is, it's an organ. It's very similar to the way that we might handle some of these other things. And so if something is nagging and it's bothersome and you don't like it, you might try to do things to correct it. And if you can't, I'm not saying that someone should wait and try to do everything for themselves first by any means. That's how, that's kind of my own personal experience. Like, I'm going to try to do it myself first just because it's my personality, it's my nature. But then eventually I reach this point where I'm like, okay, like it's not really getting better with with the changes that I know that that I've made. Like, I improved my sleep, I improved my diet, I improved my, I started exercising. I'm saying if I had depression, these are key things. Like I'm, reaching out socially and trying to do social things and engaging my brain, trying to engage cognitively. Those are like 5 key things that I make, essentially universally recommend to patients after doing TMS to try to like sustain benefit or even try to improve on the benefit that they may pick up. And I'm doing all the things that I know and it's still not getting better. And that's even if it doesn't feel like it's impairing my function per se, that's a loose definition, right? If I didn't ski, then I may not have, it may not have gotten me to the point where I'm making all these changes. It was bothering me running, but I could kind of deal with it. So I think everyone kind of goes through that process, right? You had 7 years, 6 to 7 years that you're like doing what I was doing for a few months, where trying to kind of like trying to deal with it, trying to just, maybe, are there things that you did to try and improve it on your own?
Well, I guess not on my own, but like I did have a therapist, which I thought should help, but it didn't.
Yeah.
But other than that, well, eventually I started exercise, for example.
Yeah.
And you brought some for me at that time.
Yeah.
Yeah.
How did you know to do that? I mean, did you do it for the purpose of trying to get better with, the depressive symptoms?
That's a good question. I think I mostly did it because I felt like it could improve my cognitive function, like ability to focus and stuff, which is like related.
Yeah.
Because
that's one of the kind of the core symptoms of depression is concentration and kind of cognitive focus and things like that. Yeah.
But I remember like after I completed the research study, like with TMS, and like you emailed me like saying, oh, like this exercise and eat well, and like yeah, okay, I'll do it. If you say I should do it, I'll actually take it seriously. Which I did. No, but I mean,
good.
Good. So yeah.
I'm glad to hear that at least someone talking about one later.
Yeah.
And that's just based on data. Like, it's not like my, it's my personal experience. It's, like large data studies that have shown that these things are helpful. And so.
But I also like saw some videos, for example, like there are like YouTube channels about like, I guess, mental health, and there are like videos about, you just need to exercise 4 times a week and your depression will go away.
Yeah, that's another, I think, important point is because there's so many different types of depression and different severities within that depression. I mean, everybody is different. And so there's medications that are going to work so great for somebody and that are going to do nothing for someone else. And there's, TMS. Some people get no benefit from TMS. Most people, speaking of TMS, like I would say most people do get something, even if they're not a responder, which means 50% improvement in their symptoms by, various scales. I would say probably 90% of people, and maybe 95, get like, they notice something, even it's like, like their scales are identical, they haven't changed at all, but they notice that I feel a bit more able to like deal with things that come up that are annoying or things that are, challenging or something like that. I feel a little bit more like just able to handle it. So you kind of get that type of description, even if there's not a response. And fortunately, there's some people that respond quite well. Like so you did kind of a special protocol with TMS. So most of the TMS that we do and pretty much everything that's covered by insurance right now is daily TMS.
Yeah.
And it takes a while. Like people usually ask, how long does it take to get better with this? usually it's not for like 20 sessions, which is 4 weeks. That's like an average, could be much sooner, could be much later for someone. And so we see, usually like on average, people will be starting to turn a corner around there. If someone's not, ideally we can keep treating them, because we do see that as we keep treating people past 36 sessions, which is what insurance usually covers, a good percentage, like over 60% of those people will get better, even if they didn't have any response in the first place. So there's something to be said about that. But you did a protocol that was condensed. And so there's this, what's become pretty well known in the TMS world as a SAINT protocol. This was 5 days, 10 sessions per day. And we did a kind of an abbreviated part of that as the study, where we were trying to understand how this protocol worked. And so that protocol, worked very well. And, we wanted to test neurophysiology components of this to kind of see what this was. And so you did a 3-day study. What was kind of the experience of, as far as like the symptoms and what you're experiencing from, right before to during those few days and then subsequently?
Yeah. Just for the viewers, this is called like accelerated TMS, right? The 5-day one.
Yeah, accelerated TMS.
And I did like 3-day version of that.
Yes. Yeah, we generically call it accelerated TMS. Yeah.
Yeah. Yeah. So I think like for me, I mean, like before that, my main symptoms that like were bothering me was like I had very low energy, and I also like, in terms of, especially like for my work, which was what was detrimental, is like I could not focus. Like I would, try to read something like a paper, and then like I couldn't read it. Like I would either like get really overwhelmed or like just like too many thoughts, and like I just could not focus on the thing, which is like not very good.
Yeah, it's a problem when you're in a PhD program.
Right? Exactly. Yeah. And I guess like also like I think it's called
anhedonia.
Yeah, that thing.
Sort of specifically means like hedonic is pleasure, right?
Exactly.
So it's like a lack of.
Yeah, so like I did not really enjoy anything in particular. Like do different things, I would just like not get any satisfaction or enjoyment from things, which is like also kind of hard. Like,
and that's kind of that's really one of like the core things, and people would say is sort of kind of the core, whether it's lack of pleasure or especially like a lack of motivation or a lack of interest in things. But yeah, that's kind of I would say a lot of the symptoms are sort of kind of maybe spokes of the wheel, and that's like kind of a hub of depression.
Yeah, I think these were like the main things mostly. Also like anxiety at some point. Okay.
Yeah.
Well, okay, after TMS, I think maybe like a few weeks later, like a month later, I sort of noticed that I was feeling different. I was like, I feel positive for some reason. Or like, I'm able to sit down and focus for a couple of hours and like actually read something and do something. For me, like, it was a big thing. Again, especially with my PhD work, it's like, it was kind of like.
And so you didn't notice it immediately. You noticed it a little later.
A little bit, but not super late. Like maybe like a few weeks later. But also like during that time, I did fill out, there are like this like burns, depression scales or anxiety scales. And like I was tracking that every day, kind of. So like I have like a trend.
Yeah, you can kind of see it.
Scores. Yeah. I filled out those forms and I was like, whoa, like I'm in the normal range. Which is like, whoa.
Cool.
Because like when I was filling out the scores like a year before, like in like last spring and stuff, I was like very high at the top, and I was like, I could not even imagine that like I could feel different.
Yeah.
I could not imagine a version of me that would feel in the like close to zero range.
Yeah, I hear that a lot.
So if you just
in the TMS world, like because these are treatment-resistant depression people, so
so and I guess like so I was very surprised, and then I was like I could not really believe it for a long time. I was like, maybe just like, also I was worried that it's not gonna last.
Yeah.
It's not gonna last. I was worried. I was like, okay, a month has passed and like, I feel okay. Okay, 2 months passed and like, I still feel okay. Like, okay, 3 months.
Yeah, that's awesome.
So I guess, it's still hard to believe sometimes. But yeah, I feel like another thing that I noticed is like, I'm not as sensitive as I was before, like towards like negative things, or like if something happens, like even if like a small thing happened before, like it would really like ruin my day, or like cry almost from everything. I guess that was like another aspect. I was like very sensitive, and then now it's like things happen, and I'm like I'll deal with it.
So it's kind of interesting, right? Like, you know, as you're talking about that, like some of the thought distortions that we all have, like overgeneralization or catastrophization, right? Like based on something little, and that kind of shows the interplay between like these biological treatments. Because if you were getting cognitive behavioral therapy, which is again like definitely recommend to everyone, really, that would be something that you're focusing on, right? And so you kind of be talking through and practicing over time. And, you know, so there might be more than one way to get at this changing. And obviously, like it was TMS in this case that was able to kind of get you to the place where hopefully you would have eventually gotten from the therapy if you kind of kept at it for long enough, where it's like when, you know, this thing happens or that thing happens, that you're able to reframe it and you know, immediately assess, because we have these assumptions that come up in our own head and we just don't believe them. We don't challenge them. And so it's like, it takes practice to do that. But you got there through a different way. You got there through TMS, and presumably in the way that I think of things and frame things biologically before, through strengthening those same networks and circuits that you would have been strengthening or changing. I shouldn't say strengthening because it can be different, you know, bidirectional, but you know, same thing as, you got through TMS, so that's cool.
Yeah. Also, just wanted to mention, like when I was doing the TMS study, I did have a good CBT component.
Oh yes, yeah.
Which I think was also like interesting. I don't think it was like the main thing, but I definitely found it helpful.
Yeah. We did have that in just for the listeners, I guess we have this. It was a 3-day TMS study, and then we also had. And I don't know what you did, by the way. I don't know which group you were, because it was all, you know.
Oh, are you allowed to know?
It was all blinded. Yeah, I could look at it soon. I did look at it before this, but I could look after. Yeah.
No, I can tell you because I know. So I told you about what happened before TMS and after, but during TMS, the reason I skipped is because there is a story.
Oh, okay. Gotcha.
So like during the TMS, so I did the research study that I guess you organized or directed. So it was like a 3-day protocol. And then, okay, backstory. So after I tried those 3 antidepressants, and then I gave up for a bit, and then I came across like this TMS concept, and I was like, okay, let me try. My psychiatrist sent the form to McLean that like maybe I might qualify. And then he was like, oh, there's also like those research studies, which I had no idea about.
Yeah.
And he was like, okay, maybe like even if your insurance doesn't cover that because you didn't have enough, like those antidepressants, maybe you can at least do the research study, which like is usually covered, or like you get paid to do it.
Yeah, exactly. Yeah.
Like I didn't know about that before. And so I was like, okay, like let me see what that is. So I had like consultation with the professors clinicians there to learn about this. And then like, okay, I had to fill out some form to get like approved that like I qualify for this research study that you organized. But I guess the catch is that like when you do a research study, you don't know which group you're assigned to.
Right.
Because you basically like, there are multiple groups. Like when you have like the full protocol,
you get randomized.
Yeah, you get randomized and then the other ones like you don't get anything pretty much, right?
Yeah, we had set this study up so that everyone gets something.
Yeah.
But between therapy, TMS, and the drug.
Yes. Yeah. So, but basically, there was like some chance that like I wouldn't be getting TMS. Yeah. And I wouldn't know about it.
Yeah.
Because it's like a randomized control study. Yeah. That's what the research study is.
Yeah.
So like this was like another consideration for me. I was like, I don't know what I'm doing technically.
Yeah.
But okay, so after I think the first day, the first or the second day, okay, I think it was the second day. Like at the end, the TMS was like a day-long situation. It's like 10 treatments.
It's a very long day.
Something every hour or something like that. A lot. So I had to spend all of the day at the hospital. But then like by the end of the day, either day 1 or 2, I started to have like distortions in my vision. And I never had that before. Like you look at a straight line and it looks curly.
I remember this now. I had forgotten that. I talked about this back when that happened. Okay.
And I never had problems with my vision before until I took bupropion and I had double vision. And then that
just dawned on me that was that happened and that was you.
So, and then like I guess your initial reaction was that like we should stop doing the study. Because it's like an unknown situation. Or like an unknown reaction. So then I had to go to like the eye doctor and see what's going on. The conclusion was that it's unrelated to TMS. But I don't know. I did appreciate the fact that you tried to explain to me why it's not related. I mean, to send me some papers, which were helpful.
There is some risk that TMS could potentially cause. It's very, very rare. And it's, it's not definitively, it's not like conclusive, but it's, they happen in proximity. And so, it's like sort of the do no harm always takes precedence over like the potential for benefit. So that's usually the physician's leaning is I'd rather not do something that would cause harm, even if there's a chance it can help. And so that's sort of the original idea of let's stop. And then it was, getting the ophthalmologist's, thoughts on that. Enough to like, okay, like, we could consider.
There were 2 of them, and both of them were convinced that it's not related. And because I did during the first day, because I felt like I did notice some change. Like I did start to feel differently. A little. Like it's not just like something is different. I was like I wanted to finish the study, even though I had this weird effect in between. So I basically finished that. So that was my experience during TMS.
Interesting.
So I did want to continue because I did notice something. Changing. But it was a strange experience. I also felt like throughout this whole process when I was taking like those drugs and TMS, it's like I get like those weird, rare reactions that may or may not be related. And
So what kind of, besides the vision and anything else that was, a side effect for you for TMS?
No. Other than that, it was like, no.
So
I didn't have like fatigue or anything.
Okay.
So other than that, it wasn't.
So it's very common for people to have discomfort where the pulses are.
I did not.
You didn't have that?
No.
So I would say probably like 2/3 of people have some level of discomfort, but usually we'll kind of like go lower on the intensity and then gradually increase it, and the brain acclimates to it, so it's usually not a barrier. Like virtually nobody, like essentially nobody stops getting TMS because of the pain, because we can just be lower on the intensity. And then like headaches, because it's activating scalp muscles, about 20% of people get headaches. No headaches.
I didn't have like anything. No headaches. Wasn't painful. So that's why I was like excited.
And most of the other things are basically quite rare.
And like from what I understand, TMS is like one of the safest treatments.
Relative to medication.
Which is so exciting.
It is. And that's one of the reasons that people like, I don't know how much I want to necessarily go into this and take time on it, but because it is quite safe, like there's not a huge barrier to doing it. And so sometimes if people want to get treatment for something more experimental, it's not, finances might be a barrier, but, it's not necessarily, something that I am generally like willing to do. But the really important distinction is that it's something that they need to know is experimental. Like they need to know, how much evidence do we have for this? If you're going to come in and pay to get TMS, then you need to know what sort of what the odds are that it's going to be helpful, and also what the odds are of various side effects, so that you can kind of weigh the cost benefit ratio. and determine for yourself, right? And I'm the physician and I'm the one that knows these things, so I need to be the one to tell you this. And so the thing that I was sort of thinking about and deciding whether to go into or not, there's sometimes, there's actually quite a bit of, because TMS is pretty safe, I think a lot of people they'll set up a clinic and probably well-meaning, and they'll maybe advertise for things that you actually can't really advertise for because we don't have that level. So it's like PTSD, for example, there's pretty good evidence for TMS with PTSD, but I can't advertise that TMS is a proven treatment for this, or even market for it, because it's not FDA cleared. And so if someone came to me and they wanted to get PTSD treatment, I, explain the level of evidence that we have and don't have, and the risks, then, we could talk about it. And I think it'd be reasonable to do. Insurance usually would not cover it, but, but there's rare cases where they might cover something for something different. And I think that'll probably grow. But, there are a fair number of clinics that I've just become aware of where they do, they'll say maybe more than actually is, than we know, right? And so that's kind of the, and it's a really tough thing to navigate, because it's like, how do you know, right? Like, if you're the patient, it's like, you didn't train on this for 15 years. Like, how should you be able to discern that? And so, like, you sent a website, and I had looked at that, and there was some advertisements for things that were like not FDA cleared. And I think that's like a pretty, if you can kind of, it's like if I were to give advice to like a friend of, without having to consult an expert on every single question, like I want to just kind of figure it out a little bit myself, I would probably like look at, okay, what is their website advertising? And then I would look at, like, are those advertisements, I would basically search like FDA clearance for TMS and addiction, TMS and PTSD, EEG, TMS and this. And then as I kind of see those things, that would be, some level of basic guidance. But it's like impossible to regulate it. And, and another thing, well, I was going to say, like, what's practiced at academic medical centers tends to be pretty, like, you got a lot of people all around. And so if you're going to do something kind of wacky, like, people are going to call you on it for the most part. Not that it couldn't happen, but, if it's not done at an academic medical center, like that would be another kind of metric where I'd kind of question a little bit, about, like, is this, this is if I, like, don't know about the field. But the goal and intention is to try to, we have societies and things where we try to educate, everyone that's doing this, to sort of like, this is what we have evidence to do, and this is what we don't have evidence to do. FDA clearance is not like the perfect metric, because it's, it's another long story, but it's kind of more of a regulatory process than like an evidence-based process. But that's, it's one of the things that we can use is to kind of get an idea. And it is related directly to advertising and the ability to advertise for something. So typically, like a device company, and there's a lot of things outside of TMS, like transcranial current stimulation or alternating current stimulation, like things that you can take home, things that, are activating peripheral nerves and things like that. So this whole space is really exploding, and it's really hard to stay on top of. And a lot of times there'll be things like I've never heard of, and I'm like do this kind of stuff all the time. And again, like, and it's actually not that difficult to get an FDA clearance either. Like, sometimes they just have to show that it's not harmful. And so they can kind of piggyback off of other things that other people have done. But there's, just to kind of address that question specifically, there's not any kind of electrical stimulation aside from ECT, which is a totally different thing. But just like the kind of thing you can have a wearable, like, there's nothing that we use clinically. There's potential there, but there's nothing that, like, we're actually implementing right now. So kind of to that specific question, I feel like I'm sort of way out there right now, but
I guess I also, like, encountered something like that in my experience. So for me, and also I feel like this is like difficult. All of that is like critical thinking analysis is difficult to do when you're not in a good place.
Yeah,
It's like,
you're absolutely right.
Like, people are taking advantage of that.
Absolutely right.
So, like, for example, in my case, when I realized that maybe there are like some other options besides just the drugs, like one of the most popular option on the internet was like ketamine.
Yeah.
And I was like, I have no idea what ketamine is. Like, and then like I was, trying to watch some videos, podcasts on YouTube, and they were like, yeah, sure, like ketamine. It used to be like a drug that people abuse. Now they figured out that like might potentially help.
Yeah.
And like one of the companies, they basically send you like kits to your house to do like some sort of ketamine thing.
Yeah.
And then I think they also basically tell you that you will have like a virtual, like not a therapist, but like somebody who's going to guide you through that experience. And they tell you like, for example, when you take the ketamine, you should have like a friend or somebody who's going to like watch you or something. But they don't necessarily like check that or like.
Yeah.
Anyways, and like I was looking into that, and because it was like sort of desperate, I was considering it.
Yeah.
And like I was trying to understand like if that's like an actual thing, like if it, and then like I could not tell.
Yeah.
I didn't end up doing it.
Yeah.
Yeah. But I felt like there's a lot of those things on the internet. Yeah.
Yeah. It's really tough. It's like,
do you have like advice on like how to?
Yeah. It's
for example, what you said about like MTA clearance is like actually makes a lot of sense.
Yeah.
Proxy.
Yeah. It's such a good question. Like, honestly, I'm afraid I don't have like a great answer for it because it's one of those things. Like, it would be nice if a trusted person just posted, okay, here's the things that are legit. Anything outside of that, but then, it's like, then you have to have someone that's perfectly stays up on other things. There's a lot of innovation this time. And so there's so many new things that it's hard to kind of be aware of all of it. And so it's like, I'll hear about a new thing and I'm like, huh, like, what is this? If I hear about something in the research space, it's like, oh, okay, that makes sense. When I hear about something that's like full, ready to go clinical, it's like, huh? Like, I didn't even hear about that, right? Like up to this point. And so, ketamine, for example, it's like, ketamine has good evidence. It's FDA approved. The nasal spray version has ketamine, but IV ketamine has like a kind of a long history. And so, this is it's to use like the academic medical center kind of model, like that's pretty ubiquitous. Like it's all over the place. And as far as like doing things at home, again, it's like something that's hard. You wouldn't know unless you're kind of asking someone that knows about this stuff. You have to be monitored for a couple hours after you do the ketamine in the hospital setting. And so to sort of be like, oh, I'm going to have them do that at home on their own is like, I think the intention is probably good because you're making it more accessible. You're, enhancing the access to it, by having someone sort of walk you through, like if you're having a depersonalization thing or, people kind of pretty scary experiences. And so it's like to have someone talk you through on the phone, it's like, it's an attempt to try to be responsible, but like, I didn't really know about that kind of thing. Like, I know there's all kinds of different formulations of ketamine and admittedly ketamine is not like the area that I like stay most up on, but I'm around that space quite a bit and, hadn't really heard of it. And so it's probably a question that will, I've already been thinking about it quite a bit in some regards in like trying to sort of, promote awareness, whether it's to like providers or to whatever, but it's such a difficult space to stand up. Like from your standpoint, maybe you have a solution to this issue. Like what would be, do you think as a patient, like a way that everyone could access, like something that everyone would know as a resource they could look to and be like, is this legit? Is this not legit? And there would have to be a fair amount of information on there, even if it's just a list, because there can be all kinds of different subtypes of things, right?
Yeah.
Like TMS, you could have many different kind of protocols, really infinite protocols, technically, because you have all these different parameters you can change. Less so with medications, but, still a bit. And then we have, we haven't even touched on the scary word, the world of psychedelics and all of the hype there. And, just to be clear, there's nothing that's like met the level of evidence for clinical applications. So it's an exciting research investigational approach. But I would, that's kind of the key distinction. It's either like clinically ready or it's investigational still. Nothing wrong with investigational. Like a lot of the stuff that we're doing is in the investigational space because we want it to become part of the clinical space. But it's like, so what do you think is a good way if we were to kind of come up with something that would be reliable, trustworthy, up to date, and would be really easy to make everyone aware of in a relatively efficient way. This is more your space than my space.
That's a good question. But now that I think about it, well, I work on AI stuff, right? But now that I think about it, maybe it actually makes sense. Like, I don't know if you've heard about AI agents, like things around that area. If there was like a system like that where like it could pull up, the latest information from a variety of sources automatically, and it was monitored in some way. By a professor.
Because probably it could be like 90-something% accurate. And that's kind of my experience with AI so far, is like it's pretty close, pretty accurate. Sometimes it's totally accurate. Sometimes it's a little bit off. And in general, in medicine, that's sort of, even like Harvard Medical School has tried to put a lot of emphasis into, advancing this. And that's kind of the general sense, consensus, like across different specialties, is like, it's not quite there yet, but it's, there's potential there, that kind of thing. So, but I think that would make sense to me, like something where the majority of the work is done by the AI, and then it's sort of monitored by, experts in the area
that I trust.
Yeah.
I feel like for me, like as a single patient, for me, like it's incredibly important to hear something from person, a professor, a doctor that I can actually trust. So it's like not just somebody somewhere. It's like this person. And I think like maybe like one thing that I noticed in general is that like academic medical field, like a lot of professors, researchers like do like so many amazing things and like research, but then they're not delivering the public. And it's like, you have like this like HMS, profile that says like you're doing this thing, and it's like, it doesn't build a lot of like trust for me as a patient. But like, for example, there are like some professors that have like famous podcasts. Right? And then, and through those like hours of long conversations, they can actually build trust with like the audience. So like, and they have the credentials, right? So I think that combination of like having credentials, like actually being very good in this field, and also like being able to communicate during doing and like being known, but then like I would actually trust the person and their recommendations. And I think that like this, for me personally, that's much better than just an AI tool telling you.
Right.
I think that's like important.
There's like one of the challenges with this is that you can take people that are, I wouldn't say equally expert in the thing, but you can have like really, like 5 years ago, if we were in this conversation, like some of the top tier medical centers in the country, like still didn't quite buy the evidence for TMS. And I certainly couldn't speak for them. Maybe they hadn't looked at it closely. Maybe they have a different threshold for what's, maybe they need 40 studies instead of 39 or something like that. I don't really know, but there is disagreement among experts and things, and even like world leading experts might have a different view and a different opinion on things. I think it's like when you get into an area where there's sort of that level of disagreement, then it's probably like, I would say anything that would be on that site that, it's like you might have here's like the clinically, approved things. And this would be a thing where like no one's really arguing about that, hopefully. At least, I think you have a few selected experts, right? And then anything that's like, let's say we have a panel of just 5 people, and one of us like, I don't believe, like there isn't this kind of evidence for it, whatever. And then it sort of falls into the, the investigational zone. And so it's like, that's, I could see a scenario in which that kind of thing would take place. But the challenge with it is it basically is like a volunteer thing. And, physicians and scientists are like crazy busy and get even busier because of the way the systems change and bureaucracy and you know, all these kind of administrative tasks and things of that nature, and compensation pressures. So I have to see more patients, and so it makes it really difficult to like to volunteer their time to kind of do these things, even though it's a really important, I mean, that's why I'm here with you. Like, it's a really important part of what we're overall trying to do is to like enhance, you know, the well-being of people. And part of that is making it aware. And it's one of those things that I truthfully, I feel like I'm not so great at like the public interfacing side of things. I know some people that are like really good with it. And it's something that's talked about, you know, in our scientific conferences and things like that. Like, you know, we need to get out and really interface with the public and share this, you know, it's like we kind of know all these things. It's like the Grinch where he says, solve world hunger and tell no one. So it's like, we gotta like, you know, put out the knowledge that is, you know, being acquired. But I, you know, it's like, I really do like the idea of what you're, you know, sort of this general question, this thinking, you know, whether that's like an AI generated and expert approved or expert verified or, you know, something of that nature. But it would be great if there were, you know, it's like at least in the mental health area where things are so rapidly expanding. I don't know if there's as much of this gray area in some of the other specialties, but you know, as this, there's so many like parameters, so many different ways to be able to access the brain, that even the kind of tools that we have just have so many choices within them. And I just, you know, I don't know that there is as much of that in other specialties. So at least, you know, and maybe especially on the mental health side, I think that would be kind of a game changer in terms of, you know, making it aware and then sort of somehow kind of blasting that out, so that it's, you know, is brought to people's awareness.
Yeah, there's a lot, like, now that I think about it, I feel like the way that, like, me as a patient, like, the way doctors interact with like my psychiatrist was like, they say something, and then they immediately go on Google, and then they pull up the first link, like the most popular one, which is like not, you know, an official website of like some trustworthy kind of like source. It's like just a popular website that everybody goes to,
right?
And
or something that was sort of like
ranked high,
like brought up
exactly. And like, again, because I like kind of like more rigorous kind of like approach, I was like, that's so strange, you know, you just like give me the first most popular website and then like you tell me that I should trust it. But yeah, so I feel like if there were like actual experts who were sharing more, it would have been helpful. And especially I feel like with TMS, like if you actually try to go on YouTube and like find information about TMS, it's extremely limited. And it's like, was one of the motivations why I wanted to talk to you. It's because even though there are like some hospitals that like, they have like some very short videos about like, so TMS is this thing, and like they talk in a very boring way. They're like, oh, it does this, and it's like, sure, but it doesn't build the trust enough for me to like say, this is something I want to do as a patient.
You know, trustworthy, like National Institutes of Health and the National Institutes of Mental Health, NIMH, like, you know, anything that is on their website, like trustworthy. And I think even places like, you know, well-known hospital systems, it's like if my family or a friend were to be like, hey, I found this on Mayo's website or Harvard's website or, you know, Cleveland Clinic's website or some, you know, like these tend to be like, you know, pretty closely vetted. They wouldn't publish it because their reputation's kind of on the line, you know, that they wouldn't want to have something that's not accurate. And so like if someone was not going to have access to a person that they trust, like these would be sources and websites that I would, you know, sort of look to and trust. But where it can be a little bit tricky is, well, just because they're not coming on take home ketamine or, you know, EEG based, you know, TMS or something like that, like doesn't necessarily mean that, you know, it just means that it's not there. So that's kind of the tricky part is like, it's like if you see it there, then that's a positive affirmation. But if you don't see it there, does that mean that it is not, like, or you look in the wrong place or so? So it's like kind of to be able to see, like, have a place where you can kind of verify this is not yet. This is still investigational. That would be the thing, because I don't know of any websites, that I've seen where people are like, this is still investigational, right? Like, so that's so you can kind of get partway there, through some of that stuff. And, if you're looking through, McLean's website, for example, like, and you're not seeing anything that's being addressed, then, it might be, it's like, if you're going conservatively, then I would maybe just stick with, with what's there.
That makes a lot of sense. Okay, I guess like maybe in the remaining time, one thing that I thought would be useful to discuss is, so like one part that important part that we discussed is like kind of like recognizing when it might be time to seek help.
Yeah.
And we addressed that more.
Yeah, I think so.
Okay. But then
I even kind of addressed, the if it's like urgent or emergent or something.
But then the next step is like knowing your options and like what's available, different kinds of treatments.
Yeah.
And my inspiration for this part was that, again, I think like when, last year when I first, went to my doctor and I was like describing how I felt, it's not like they outlined to me like what's available. They were like, take this SSRI.
Right.
And that seemed like
they didn't present all the options and then let you choose.
Yeah. And then while I was doing the TMS, I remember, I think Julia. So I liked all the entire team. I think everybody was so nice, and like it's like the most compassionate team that I feel like I've encountered.
It's awesome.
In particular, the way Julia talked about like treatment options.
Yeah.
That was like the first time somebody outlined to me. It's like, first, it's like you try antidepressants. If they don't work, you go into the next step, maybe TMS, something else, ketamine. Then if that doesn't work, you go like ECT or whatever. And then if that doesn't work, and then she was like, there is like possibilities.
Yeah.
And I felt like that was inspiring to me.
Cool.
Because I was like, and also like, the way she talks is like, very nice. So
she is, yeah.
Anyway, so I guess that was like backstory for you. But for the viewers, I guess, could you try to like outline kind of like this possible options?
Yeah, kind of from the beginning.
Yeah.
I'm explaining with the brain, we have 3 different ways to access it. We kind of already talked about this biologically, right? But we have talk therapy, we have medication, and we have brain stimulation therapies. Everything kind of fits into these, in somewhere or another. And so, usually, sort of like with your story, like there's very little risk to therapy. The most maybe being like if you're doing exposure therapy for PTSD and it brings up a lot of, negative feelings or something like that. But hopefully in the right setting would happen. And so it's like, there's no downside to starting that. Medications can have some adverse effects, as you experienced. And, most people will tolerate them fine. And there's, so it's like a lot of times those are started at the same time. Maybe one can be before the other. I think, in general, my thought is therapy is always good to have, like all the way through, ever, like for the rest of your life. If possible. And if it's beneficial.
For depression specifically, is it like CBT the most like?
Yeah, CBT is the most evidence-based. It's the most common. I think it's very effective. It's kind of like a more practical kind. And the other sort of really major branch would be psychodynamic kind of therapy, where it's a little bit digging into more like what's the root cause of this, and trying to understand where these things came from. That's where you kind of the more classical, like getting into your childhood and understanding sort of where these things came from, and and then medication, you have a lot of options. There's, like maybe 30 different antidepressants or something that you can use. The older classes, like the monoamine oxidase inhibitors and the tricyclic antidepressants, these are medications that a lot of times will go to sort of more like down the line because they tend to have higher adverse effects. So most of the time, like and it's very reasonable to start with a primary care provider. And it would be the same as, the psychiatrists, they like, oh, you have depression, we'll give you an antidepressant, right? Like, and that's quite simple. Doesn't really take, genius to be able to figure that out. And so they'll start you on like an SSRI, which is the most common thing to start with. SNRI. I think we kind of already talked about these acronyms, but serotonin noradrenergic reuptake inhibitor. There's a few of these, and kind of talked about the rationale with them as well. So it's kind of like list a little bit. You have, Wellbutrin is kind of its own class. Remeron or mirtazapine is kind of its own class. You have, with medications as well. This is where ketamine is a medication. Psychedelics are medications. Psychedelics, I shouldn't have included in the same thing because everything is investigational there. Ketamine is not technically psychedelic, but we kind of sometimes group it. But ketamine is, is an approved medication, although it requires more, it tends to be something that we don't just write a prescription for this. It's something that you have to do, in a clinic where you can be supervised. And so we treat it more similar to the brain stimulation things because of that, and it tends to be more of like a down the line thing, and there's more risks with that. And so a lot of times people might tolerate TMS better. And so basically once people have tried a couple of these from a couple of different classes, getting therapy, not responding, then you kind of look to, what are some of these more involved therapies? That's where, TMS is really probably like front line with those, because it's, you don't have some of the adverse effects that you can get with ketamine, but ketamine and TMS, I'd say, are pretty close in terms of which one to go. They both tend to be for people that are functioning okay. So if someone comes in to the TMS clinic and they're still going to school, they're still working, they just are not doing great, and they want, they're there for help. TMS is great for that. And ketamine also can be, because it allows you to continue to kind of function normally. If someone were like not doing well at all, the things we talked about before, like if they're, feeling more suicidal, or they're not able to, like, they're not eating and they're losing weight and things of that nature, in addition to potentially inpatient, and sometimes people can get so severe, they can actually get like catatonic, they can have psychotic features. These are things I'd be like, ECT, and I would go right to that therapy. But otherwise, ECT is still considered our most effective treatment.
Of all of them?
Of all of them. Although I would, I'm hopeful that in the next couple of years, some of the mechanism guided TMS approaches, I think could put these at a higher remission rate than ECT. So I'm hopeful for that. And it's better for people because it's a bit less invasive. ECT is still really very safe. The way that we do it now is much different than they did it in the 70s. It's much less electricity. It's like very ultra brief pulses. You can do it on one side of the head, that dramatically reduces cognitive side effects. That's like the main concern with ECT, is the cognitive side effects. But you also have risk from anesthesia. There's kind of a number of risks that are quite rare. It's all closely monitored. And so a lot of things, we tend not to see it. But the thing that we do know is, like, you do have to take time off of work and school, because it's going to affect your memory around the period of those treatments. So studies have shown that, especially with these kind of right unilateral ultra brief pulse that I was describing, is what we call it, memory before this compared to memory 6 months later, it's actually better later, like after the ECT. Doesn't mean that some people might not have some adverse effect from that and the cognitive side effect, cognitive profile, but the point is, it is safe. As far as like our treatments go, like every treatment has some risk, but
like the memory loss is like the main
exactly
concern.
Yeah, that's like,
but it's supposed to be tempered.
Yeah,
most of the time.
Exactly. Yeah, that's the point. Is like, it's so you should, like, if you were going to get ECT, you would need to do that. You need to basically stop going to, like, you need to take a break from school, whether it's in the summer or whether like it was severe and urgent enough that you had to like stop the semester or whatever. Because you'd probably be like 6 to 8 weeks that you'd be out of school or work where you are getting the treatments. And so ECT is a really valuable, resource in the field. And severe adverse effects from ECT are like extremely rare. And so I would consider like a very safe treatment.
Interesting, yeah.
And
I haven't heard of it much,
yeah,
I was trying to read.
it's our oldest treatment. It started like in 1937, but
Yeah.
the technology with it has advanced quite a bit. Yeah, so I think for people that haven't responded, I would typically start with TMS, maybe then go to EC or go to ketamine. Like if TMS didn't work, maybe try ketamine. Add one caveat, like it's still investigational, but pharmacologically augmented TMS with an NMDA receptor agonist, which kind of enhances that mechanism we were talking about. D-cycloserine, like this is close to being at a point where we'd be able to implement this. And this is where I think we could see those really high effects. And so we should do this again so I can make a clinical recommendation because it is still investigational. So it's like you try those, and then I would kind of go to ECT. And, if one of those works, a lot of times you can kind of keep using that again and again, even if you relapse. And if you've gone through those and none of those work, then I'm thinking of more invasive things like vagus nerve stimulation. Deep brain stimulation is investigational, but is I think could be coming around. So that's kind of the sort of the general workflow that I would have across the treatments for depression.
So you mentioned that depression is like not curable.
Yeah.
Can you elaborate a bit more on that, and also like how that relates to like different treatment having like different durability? Like for example, if I knowing all of this now and being much more aware of like possible options, like suppose I decided I needed help and I decided I still wanted to take an antidepressant, even though I know that like the effect is gonna go away as soon as I stop taking the medication. With that in mind, does that mean like that while I'm on the drug, I'm supposed to like implement some changes in my life or like do this therapy or something else that would help the change to be like more permanent? Or like what is like the overall strategy should be?
Yeah, I would say yes. I would always try to emphasize like the behavioral things that can be done. Again, I kind of think of, say like my whatever predisposed me to getting this knee injury, that I was talking about. Like if there's some rehabilitation that I can do that's going to make that better, I'm going to prefer that over some more invasive option like an injection or surgery or something like that. If I needed to get a surgery, like regardless, I would still go back to and focus on whatever could help prevent it from happening again. So whatever ends up hopefully treating this and getting it back to 100%, then I would do my best to try to like maintain that. And the things that can help, because whatever, like we talked about it not being a cure, there's this predisposition that you have towards depression. Like that's why it manifested when you were a teenager and, started independent of whatever you were doing. And then there's things that can help kind of resist that and prevent that. And so to focus on doing those things is like, if you kind of think of it from that circuit biological thing, like if let's say there's underactivity of this particular circuit and you've kind of figured out some sort of thing, whether it's exercise, whether it's some sort of cognitive behavioral therapy, whatever, may be, and that thing is like helping with that, then it definitely makes sense to kind of continue that perpetually, because likely if you kind of just stop doing all that, then it's a good chance it'll sort of go back to the way we're, similar to like the cancer analogy, like you've stopped all the treatments, you've cleared out the cancer, but there's still those like genetic aberrations that, you have too many promoters and not enough suppressors. And so, and that's why like, for example, with breast cancer, people will get prophylactic mastectomies, or maybe after they had the cancer, they just, they took it out, but there's such a high risk for getting it again. They're just going to like, do a total double mastectomy. Like, so there's these, they recognize that there's this really high risk for recurrence. And, some people have a much greater risk and it's going to be more aggressive, more severe, more frequent, some less, there's just a continuum. It's not like a categorical, of course, of a variability in that. And so, yeah, so that's why, there's not a cure in the sense that like it permanently changes, and the brain it's beneficial for it to be plastic. It's beneficial for it to, and even it's like, there's things that are adaptive about depressive symptoms, even like if you're pushing yourself too hard, like it can be, the brain could be like, we need to slow down. And so you can kind of have a slowing, or maybe you need to like be more attentive to something. You might get a surge of adrenaline, but this kind of can correspond with anxiety. And so all the things that we kind of experience, they can be adaptive, but it crosses this sort of line into maladaptive, and it's kind of gone too far. And so that's it's kind of goes to the question we were talking about and the things we were talking about before with how do I know if this is something I should seek treatment over or not. And so the maladaptive ties into is it changing my ability to function normally or not, and that kind of by definition is what maladaptive would be.
Yeah, I feel like sometimes it's like difficult to tell it yourself whether you're not functioning normally if you have been in that state for a long time.
That's a great point.
It's like,
it's true.
You need somebody from the outside.
Yeah. And you always have to kind of take a step back.
Yeah.
And kind of look at like.
But it's so hard.
Yeah.
Especially if you're a little boy.
Yeah. Yeah. And so there's some sort of like a saying of, you can either take time to I wish I could remember the quote. It's like, because it's said much better than I'll just kind of slaughter it and just say like, it's like you can take time now to kind of keep yourself well and try to, do prevention, like an ounce of prevention is worth a pound of cure kind of a thing, or if you don't take time now, then you'll surely take time later, to be ill, and the body will kind of respond to that.
I just remembered, like, you asked me, like, what was the like point when I decided to take this more seriously and actually try to get some help. I feel like it was like a comment or a question from like one of my friends, which was basically about like the fact that like my normal might not be actually the normal. Like the things that I'm used to, like the way my life is, like the way I feel and function, even though I've been feeling and functioning like that for many years, it doesn't mean like it's normal.
Yeah, that's true.
And it's hard to notice that when you're in it.
Yeah.
Which is nice.
Yeah, and a lot of times we kind of think of it as like, how have you been for a while? Like we'll sort of, people have different baselines, and so we'll sort of we'll want to compare it to their baseline. But if all you can remember is, feeling that way, I remember one of the patients that I remember from residency training, they had been 20, like several decades, they'd been feeling depressed. And then we treated them with TMS, and I remember she was saying, it's like, I never thought that I would ever feel different. Like I was just very much accepting that this would be how it is. And she totally, she felt like full remission, felt totally better. And I was like, wow, what a powerful tool this is. Like, so that was one of the kind of the clinically motivating things, in addition to the scientific side of things, that led me to continue, to think that I want to focus my career on this.
Yeah, that's inspiring. I feel like you're doing such an important work, like as a researcher.
Oh, thanks. Yeah,
cool.
Definitely very rewarding.
Okay, last question. I was just curious. So we discussed like those online resources and how to look for websites potentially. But are there like any specific websites that you feel like might be helpful for people to be aware of, or like any resources or books, broadly speaking, that can like help them navigate this sort of journey? In particular, one thing that came to my mind was like, for me, as like somebody who like couldn't acknowledge kind of like whether I need or not help.
Yeah.
Do you think like there are like some not service questionnaires that kind of like try to estimate your depression level or something? Is that like a reasonable first step?
Yeah, it's like.
And actually, during the study, the TMS study that I did, you also had like a bunch of those scales.
Yeah, we were assessing all kinds of things with that. Yeah, like so scales that you'll often take like in a doctor's office, even like a primary care office, would be like a patient health questionnaire, PHQ. You have 2 and 9 question, assessments, and they just kind of like, ask some of the things that are these kind of core symptoms of depression. And I think that those can be useful to kind of examine, so it's like if you've been existing in this place for a long time, like I think it's reasonable, and they're hard to answer honestly, because it's, it's like a 1 to 3, like how many days, like it's a, one of the things that's sort of the dream is that we can just, have these clear biomarkers, like maybe it won't be a serum test, but maybe it's like a facial or voice, so there's efforts to sort of have these objective biomarkers. And it's tough for researchers too, because, we know how variable it can be in people answering these things, but it is the best that we have right now. And so, at the very least, it kind of gets someone thinking about do I have thoughts of death? Do I have thoughts of suicide? Like, if that's not something that's really strong, how is my sleep? How is my appetite? How's my concentration? And at the very least, it kind of gets you thinking a bit more about that, and maybe recognizing yeah, I actually do have quite a few symptoms, and maybe I know exactly what it is. For me, during quite a bit of time during training, it was brutal. It was so challenging, just busy. And so I didn't feel great, but I knew why. So I kind of I'm I feel confident that if you took this away, I would feel good tomorrow, so if you know what it is and you took it away, so technically, there's primary depression, and there's essentially depression that's induced by other things. We would maybe call it adjustment disorder or something like that. Depends on if it's drug related, we call it substance-induced mood disorder. So there's other things, but still, if it's creating a challenge, it's very reasonable to be well, I can't stop this job, or I can't stop this program. Maybe that your PhD program is the cause of this thing. You felt fine before it, and it's the beginning of it, right? It's well, if it's, if it's if you need help while you complete that, then, this is your new reality. And so, and maybe in theory you could stop it, but in a sense you can't. And so, then it'd be reasonable anyway to, to kind of get help or treatment.
Well, thank you so much. I know how busy you are, so I really appreciate that you took the time.
So I think it's actually a super important thing. So really glad that you did this podcast. I think it's really critically important.